नमस्कार व्यूअर्स। आज के टॉक शो में देश के जाने माने पीडियाट्रिक नेफ्रोलॉजिस्ट डॉक्टर आनंद वासुदेव जी का स्वागत है। आप इंडियन एकेडमी ऑफ पीडियाट्रिक्स में वरिष्ठ सदस्य ही नहीं, संस्था के हित में काफ़ी कार्य करके अपना आज देश में नाम बनाया है। आप बच्चों के यूरिनरी ट्रैक्ट इन्फेक्शन में नए आयाम पर हम सभी को अनुग्रहित करेंगे और हमें बताएंगे कि क्या जरूरी है। He is a senior consultant pediatric nephrologist, Indraprasth Apollo Max Holy Hospital, New Delhi. National Vice President in IAP in 2020. Vice Chair की Pediatric Kidney Foundation, visiting faculty, Wisconsin, USA. His major achievements are editor-in-chief IAP textbook of pediatric nephrology, editor algorithm in pediatrics, editor in IAP textbook of radiology. He has received many awards, honors. Bal Gopal Award of IAP Best Paper, Sarla Vaishnav Award of IAP Delhi in the Best Paper, Young Scientist Award of Department of Science and Technology. He is still young, for that. Puneet Sharma and Oration Award 2020. Dr. Gopal Sharan Oration at Bihar Pedicon 2019. AP State Oration at Vijayawada 23. Many awards to his credit. There are many publications, over 50 publications in national and foreign journal. It's really creditable at this age, when he is so young. Large number of chapters in books, delivered over 1,000 talks in national and international conferences. I invite Dr. Anand Vasudev for this talk, precious talk, to the viewers and pediatricians of the country of Indian Academy of Pediatrics and all around world, to listen to him and come to know what are the newer avenues in urinary tract infection in children, to save the children for the future, so that they are not suffering from the kidney diseases in the future for the kidney transplantation. Welcome, Dr. Anand. Please share your talk, slides and continue your talk. Welcome.
Thank you very much, Dr. Tuteja, for inviting me. And it's a privilege and pleasure to be on the Dr. Tuteja's talk show. And I know through him we can dissipate knowledge which is very useful and practical for our pediatric friends, and not only pediatricians, but all other medical professionals also. And even sometimes educated parents also can benefit from it. So with these words, I would like to start my talk today. And as already highlighted, I'll be talking on the newer guidelines which we have released recently in 2024 on urinary tract infection, their management in children. So can I share my slides now?
Yes, please.
So I said the urinary tract infection and what is new in it, and what are the recent guidelines which have been changed. And as already introduced, I am working as pediatric nephrologist in various hospitals in Delhi, and I have been going around in the country for education and mentoring youngsters on pediatric nephrology. So once we come to urinary tract infection, we know that it's a very common bacterial infection in children. And even I was surprised when I came to know that it is second only to the respiratory tract infection. And we see so many respiratory tract infections in boys and girls day in and day out, but are we really seeing so many UTIs? If we are not seeing so many UTIs, that means we are missing the diagnosis. And why the diagnosis is often missed? Because the symptoms are very non-specific in children, and we'll see in next couple of slides how we miss them. But what is the risk of UTI and why are we so worried about it? The risk is about the scarring, and almost said that 15% of children who have febrile UTI may end up with renal scars which can have long-term implications in children as well as in adolescent age, and sometimes going on to even the adult age. Now, there are a few learning points which I wanted to highlight, and basically, just give me a second. These learning points, okay. So these learning points, what I say is that if you have a child whose fever is not settling and there is no focus and there is sepsis, think of underlying urinary tract infection. If there's a newborn who has got sepsis, who has got hypothermia, who has got a prolonged jaundice, not the routine jaundice which can be taken care by phototherapy, but a prolonged jaundice, think of underlying UTI in these children. If the child has got unexplained vomiting and diarrhea, which is such a very common phenomena in our pediatric age group, that children will come with vomiting and diarrhea, but some child who is coming again and again with vomiting and diarrhea, think there's some infection underlying and UTI may be the cause. If the child has got failure to thrive, child is not growing well, the height is not achieved, and child is not gaining weight, he may be having underlying urinary tract infection. So all these are subtle things which do not point to the UTI directly, and very, very occasionally, once you have symptoms like which can be seen like dysuria and hematuria or other urinary tract anomaly, they are very visible and they can be very well figured out, but these will be very, very less often and they will speak for themselves. Right. So once we are talking about the urinary tract infection, we know that very important that the urine examination has to be done. And collecting the urine is the first and foremost thing where normally fallacies may occur because the parents do not know how to collect the urine. And we have to educate them. One way to collect the urine is by applying the urine bag. But this gives very high contamination and high false positive rates. So it is useful only for ruling out UTI. If you have a bag specimen, it's good for seeing the routine examination and chemical test, but not for the culture. If a culture is done and it is negative, that means child is not having UTI. But if it comes positive, do not take that culture into consideration and just garbage that report, I would say. Do not pay any heed to it. Next is the clean catch specimen, and this is the most often used is the clean catch specimen. In toilet trained children, it's very easy, but sometimes in non-toilet trained children, it may be a little difficult. So what we say that you can clean the child, and perineal cleaning and midstream urine is very important to reduce contamination. So clean the child, and after that, the child can be lied down, and we can what we call as stimulated voiding can be given. We can tap the bladder area. I just give you a example that if this is a child and he is lying down, you can tap the bladder area very, very quickly and the child can pass urine. Sometimes you can put a cold swab on the bladder and immediately the bladder may contract and the child will pass urine and you can collect that without touching the private parts. Occasionally, we need the catheter sample, especially in hospitalized children, or suprapubic sample very, very rarely in hospitalized children. So, but once you have collected the urine, the transportation again is very, very important and it should be transported quickly and plated quickly. Suppose the child has come at middle of the night and the urine has been collected, then you can store that urine in refrigerator at 4 degrees centigrade for next few hours till the laboratory is open and then you can give it. But don't keep it for very long, otherwise it will give a false positive overgrowth of bacteria. Now, what changes have we brought in? I'll not talk about the simple urinary tract infection, which almost all our friends know about it, that they have been doing. So I'll see what changes we have made in these guidelines, which are very important for our pediatric friends. The first change which we have made is that we were always sending the urine for microscopic examination and relying on microscopy, what we called as the chemical analysis. But now we are saying that for the preventive treatment and diagnosis, we can use the urine dipstick. These are very convenient dipsticks, and you can dip it in the urine, and within 30 seconds, you can get the result. And they can give estimation of two very good enzymes. One is leukocyte esterase, and the other is the nitrite. And this is used as a first-line screening test for urinary tract infection. If both are positive, there's a very high sensitivity and specificity. And next, we can send the culture if both are positive, and we can start with empiric therapy if the child is having symptoms pertaining to UTI. In the meantime, we can send the urine to the laboratory for urine microscopy in a freshly void sample, and this is an alternative to dipstick for screening of UTI. So what we have changed is that instead of microscopy first, We are now doing urine dipstick first, and then we send for microscopy. In microscopy, if there are WBCs, leukocyturia, which are often labeled as pus cells, in uncentrifuged specimen, we normally don't see, but in centrifuged specimen, if there are more than 5 WBCs per high power field and these enzymes are positive, you are more or less certain that you are dealing with a child with urinary tract infection. And then you can start empiric therapy and send the culture before that. Now, we have already talked about the positivity of the microscopy and the nitrites and leukocyte. So once the urine culture has come, the second change in the guideline we have made is about the urine culture interpretation. In the suprapubic sample, we know that any number of colony count is significant, but we cannot have colony count less than 10 raised to the power of 3. And if it is 10 raised to the power of 3, it is very certain that you are dealing with UTI. If it is a catheter sample, then 10 raised to the power of 4 is very significant to diagnose UTI. What change we have made is that in the midstream urine, we were earlier saying that colony count of more than 10 raised to the power of 5 colony forming units per ml is significant. But because of that, we might be missing a few children with UTI, and now the count has come down to 10 raised to the power of 4 instead of 10 raised to the power of 5 to have a midstream urine as a significant sample. Bag specimen, I've already said, is unacceptable for culture and it should not be considered. So this is the second change, bringing the colony count from 10 raised to the power of 4 to 10 raised to the power of 5 for diagnosing urinary tract infection in midstream urine. If the counts are sometimes lower and symptoms are persisting, that may confuse you that the laboratory is giving us a count of 30, 40,000, but the child is looking to have UTI, then it is significant. If the child has received antibiotics, if the child is on diuretics or passing very dilute urine, again the colony count can be low, but it can be significant in presence of persistent symptoms of UTI. Now, one important thing that is very commonly seen is asymptomatic bacteria. This means there is presence of positive urine culture without any symptoms. Then why on the earth we send the urinary sample for culture? So we should not be sending routine urine cultures unless the child has got symptomatology pertaining to UTI. And the prevalence is very high in boys and girls, especially in girls with low virulence E. coli. If it's an asymptomatic bacteria, that means no symptoms, but there are bacteria and culture is positive. From clinical point of view, we would say that routine urine cultures should not be performed in asymptomatic children. Otherwise, we get trapped and we have to unnecessarily start medication in these. So no antibiotics for the treatment of asymptomatic bacteriuria. I have seen occasionally when all these investigations in a child 6-7-year-old is being done for some other purpose and urine is also sent and urine comes positive, but the child is otherwise fine and unnecessarily the antibiotics go. So we should not attempt at sending cultures in asymptomatic children. And even if it comes positive, child is asymptomatic, please do not treat it. Now, coming to the treatment guidelines, what changes have been made in the treatment guidelines? For simple UTI, which is also called as the lower UTI or cystitis, there's a low-grade fever, dysuria, urgency, frequency, and the initial first-line empiric therapy pending the culture report, what we see is oral therapy is just good enough. You can use any of these drugs, cephalexin or cefadroxil or amoxiclav, and both these drugs are excellent drugs. They have got a very good urinary concentration and they can work very well. Now, the duration of therapy, in our previous guidelines, we were saying to give for 5 to 7 days, but the current recommendation is to give for shorter period of 3 to 5 days. And world over, everybody is getting concerned about the antimicrobial resistance, and we do not need to give longer courses and more potent antibiotics to simple UTI. Just 3 to 5 days is good enough. In younger children, 5 days. In older children, 3 days is also good enough. But sometimes you have complicated urinary tract infection, what is also called pyelonephritis, or in neonates, when there is high fever, there is toxicity, vomiting, renal anger tenderness, the creatinine is high, Then a recommendation is to start with third generation cephalosporins or amoxiclavulinic acid. One of them can be used as first-line empiric antibiotic therapy in febrile UTI. The antibiotic, of course, subsequently can be modified depending upon the severity of the report, sensitivity of the report. So what the ISPN guidelines, that's our Indian Society of Pediatric Nephrology, which is the key organization which is giving us all the guidelines about the renal diseases. The guidelines were last released in 2011, where we had suggested that all children with pyelonephritis or neonates should be given intravenous antibiotics for 10 to 14 days. But now the current recommendation, the changes are that we can start with oral antibiotics in all these acute febrile children, except I would say two categories: when the infant is less than 3 months of age, or the child is very severely ill and septicemic. And of course, if he is vomiting, then we cannot give oral. But otherwise, even in a febrile child, trust me, you can start with oral antibiotics. You need not give IV antibiotics to start with. And even if you have started IV antibiotics and initiated, it can be switched to oral after 3 to 4 days to complete the rest of the course. So if you have started IV, then after 3 to 4 days, if the child is well, then switch to oral, which and cut short the course, and we'll see how much is the course of antibiotics now. So shorter duration of intravenous therapy reduces the cost of treatment, time of hospital stay, risk of nosocomial infections, and emergence of resistant strains. And duration of therapy, what we were suggesting earlier, 10 to 14 days, now it is cut down to 7 to 10 days of therapy with appropriate antibiotics in children with all acute febrile illnesses. So coming to the gist of the treatment, if you have a child with urinary tract infection, if you see on the left side of these slides, if there is cystitis, that means lower UTI, give oral antibiotics only 3 to 5 days depending upon the severity. If there is pyelonephritis or complicated UTI or a neonate, if the child is less than 3 months, he's got sepsis, he's got renal angle tenderness or poor intake, yes, then we give IV antibiotics for 2 to 3 days. If there's a clinical response, yes, then we switch to oral and complete 7 to 10 days of treatment. And if the child is older one and not very septic to start with, we can start with oral antibiotics and continue to complete the course with oral antibiotic. Now, sometimes if there is no response to even IV antibiotics, then we have to repeat the urine culture to see if we have a different sensitivity pattern, and also get an ultrasound to see if there's any obstructive uropathy or any other problem where the response is poor, as in routine case. Other supportive treatment, hydration, we all know good hydration is good for UTI. What I want to highlight is alkalization of urine is not required. I see a lot of prescriptions even by good pediatricians that alkazol or some other alkalizer is used. And in today's era with so potent antibiotics, we do not need alkalization and change of pH. For fever, please stick to paracetamol and avoid NSAIDs. Cranberry products, many parents who are educated will ask you, you can use cranberry products, can be used for prevention of recurrent UTI with normal urinary tract. If there is other anomaly, anatomical anomaly, then it is of no use. And in infection, acute infection, it is of no use. Again, repeat urine culture is not required. Please mind this very, very clearly, that you have treated the child. You do not need to send repeat urine culture after 5 or 7 days of completion of antibiotic treatment. Unless the child is very sick, toxic, and fever is persisting beyond 72 hours, then you only need to repeat the cultures. Otherwise, we are not chasing till the last bacteria. Some of the bacteria which are left will be taken care by the body, and we just need to treat the child clinically. The child is well, stop the treatment and do not repeat the cultures. Now, once the treatment is over, we are happy, the parents are happy, but as pediatricians, our role does not finish after the treatment of the antibiotic courses and treating the child. We have to see why in first case, where sterile urinary tract got infected and there were bacteria in it. So there can be other reasons, and we have to do some imaging also to find out why the child had UTI in first go. So these are used, the imaging is used to detect degenerative urinary tract abnormalities and obstructive uropathy. Ultrasound is one investigation which is non-invasive, very informative, and it can give us lot of information about hydronephrosis, ureteric dilatation, bladder wall thickness, posterior void urine, post void residue, and even with a good sensitivity, it can detect 50% of the times as VUR also. So this is operator dependent. That's the only thing about ultrasound. If you find a good sonologist, he can do 50% of your job well. And it is one investigation which is required in all children with UTI. We'll come to it when we see the gist of all the investigations, but mind you that ultrasound is one which can give a lot of information. Some of these children would require MCUG or VCUG, voiding cystourethrogram, which can give us information about vesico-ureteric reflux, about neurogenic bladder, posterior urethral valve, other anatomical details of the urinary system. And I'll show you some of these VCUGs, how they can pick up these anomalies. Some of these children would require DMSS scan. This is a static nuclear scan, which gives us information about the renal scarring, but then it has to be done late after the UTI is over, at least 4 months, 3 to 4 months later, and not very early. Earlier, we were doing these scans early, but then they can give a false positive result rather than an accurate result. So delay the DMSS scan and do it after 3 to 4 months of acute UTI when it is settled. Now about the VCUG, I was telling you that in VCUG we would fill the bladder with the contrast by putting a very fine catheter, and then we fill the bladder and we see for the reflux. This is a grade 2 reflux, then we can have a grade 3 reflux, this is a grade 4 reflux, and this is a grade 5 reflux with high grade reflux, bad bladder with diverticuli and neurogenic bladder. And then we see sometimes these younger children can have posterior urethral valve. Both these boys were less than 1 month old when they had sepsis, underlying UTI. We did a VCUG. There were posterior urethral valve here, posterior urethral valve here, and hugely dilated posterior urethra with a bad bladder with multiple diverticuli. And here you find diverticulum also, and along with that reflux also. And I'll show you the DMSS scan of this child later, that at young age this child had got a lot of anomalies in the scan also. Sometimes we may pick up other anomalies like bladder diverticulum, where the child can have recurrent infections, and we may not pick up sometimes on ultrasound, but VCG may be required if the child has got recurrent UTIs. Now I was telling you about the DMSS scan, the static nuclear scan. This is how the normal kidneys look in the scan, very regular, and good contrast is absorbed by the kidneys. Here this kidney is looking normal, and this upper part is looking normal in right kidney, and the lower part is photopenic where the contrast is not there, and this is the scarred area in this kidney, unilateral scarring. And this is the child with bilateral scarring, and this is a scan of the child where there was a bilateral reflux, bad bladder, posterior urethral wall, and a few months later when we got the scan, there were photopenic areas and both the kidneys are scarred here. I've been following up this child. Now is after about 8 years, this child started having mild increase in his blood pressure, and after 10 years, some slight increase in creatinine. Now is about 14 years, his creatinine has started increasing, and both kidneys we know are scarred, and this was a problem with the child had antenatally the posterior urethral wall. So some of these children have to be followed for long term, and we have to look after them, but they can be detected very early, and we can look after the other problems and prevent UTIs in these children. Now, looking at the gist of the investigations of imaging, if you see the child with first episode, which most of the pediatrician may not see, the primary care physician may see first episode, treat the child and get an ultrasound. If the ultrasound is normal, just leave the child alone. But if the ultrasound is abnormal, then we would need a micturating cystourethrogram, and if there's a reflux in that, then we would need a DMSS scan after 4 to 6 months. But trust me, getting a first episode is very, very uncommon. These children may have taken multiple courses of antibiotics by the time they come, and you would never know whether it's a first episode or recurrent UTI. So if you have a child with recurrent UTI in your practice, a child who has got a non-E. coli UTI in less than 2 years of age, and abnormal ultrasound, then these are the children who would require an ultrasound, of course, all of them, and then they would also require a micturating cystourethrogram, and if it's a recurrent UTI, he would require a DMS scan later. And recurrent UTI, earlier we used to say that 2 episodes in 1 year, but that is not so. Now we say any 2 episodes of UTI is recurrent UTI. If the child had UTI in April and now he again has in July or June, it is recurrent UTI. And we have to follow the protocol, this protocol in recurrent UTI. Now, some of these preventions of recurrent UTI again is very important for children who are having recurrent UTI. Increasing the fluid intake, we all know if there's a vesico-uretic reflux, then complete emptying of bladder will keep the bladder empty, and the grade of reflux and the pressure of the bladder will decrease the reflux if the bladder is empty. If there is a post-void residue, the child is not voiding fully, and there is frequent voiding and double voiding. In double voiding, I normally tell children, I tell the mothers that once the child has passed urine, ask him to wait for another minute or so, and then remaining urine can be passed. Precautions in cleaning the perineal area in girls is very, very important in recurrent UTI, and we all tell them that they should be washed from front to back, and we have to be giving them proper instructions. And again, I would just give you that front to back means this is the back, and if the the water is poured from back side and then front to back cleaning is done this way, then it will not cause contamination of the urinary tract. If the mother understands this one time that the fecal matter should not enter the urethral area, she would be very, very careful in cleaning it. And what I have seen is that children who are using fixed seats and Western toilets now and using fixed jets, again, these girls, 7, 8 year, 9 year, when they don't allow the mothers to wash, they are doing themselves, and then they are messing up a whole of that area, and the genital infections can be there because of the contamination of the urinary tract. So they have to be taught adequately about the cleaning and hygiene part. Avoiding constipation is very important, otherwise recurrent UTIs will not settle. Again, diapers, I'm not against diapers, but the diapers are used in our hot and humid climate, where the mothers may try a diaper at 10 o'clock at night and open the diaper at 8 o'clock, 9 o'clock at night, and the diaper will be full of urine and stool. And she would not realize that it can contamination the whole area, and this can cause recurrent urinary tract infections. So one has to be very careful if diapers are being used, and they have to be changed every 2 to 3 hours, and mother has to be very cautious that the child does not pass stool in these diapers which can contaminate it. Some of these boys may require circumcision and high-grade reflux. Management of bowel bladder dysfunction is very important. Otherwise, these children can have recurrent urinary tract infection. And talking about bowel bladder dysfunction is a talk in itself, full length talk in itself, but we have to be very cautious if the child has constipation or bladder symptoms, holding maneuvers, is not going to washrooms and is trying to hold the urine, then it can again lead to a recurrent urinary tract infection. Some of these children may require chemoprophylaxis also, apart from the hygiene part.
Okay.
Now, another important thing I just want to highlight is about the phimosis. Now, most of the mothers, grandmothers have a habit of putting oil and stretching the penile area. Below 2 years of age, the penis is safely covered with the foreskin, and one does not need to stretch it and put oil or any other lubricant. Otherwise, it can result in scarring like this. And if the child has got a slight opening like this, one does not need to manipulate. What is important is to look for the labial adhesions in the girls. Sometimes the girls have labial adhesions which may be missed, and this can cause to recurrent UTI. So a request to all my pediatric friends that once you are seeing a child with recurrent UTI, always look at the genitalia, and you may not miss labial adhesions in these small girls. So, and one last slide about the vesico-uretic reflux. Another change which has been made in the guidelines is about the antibiotic prophylaxis in VUR. Now in lower grade VUR, grade 1 and 2, we do not recommend prophylaxis in these children. Only patients with high grade VUR, grade 3 and 5, we recommend prophylaxis. And some of these children who have got high grade reflux and got breakthrough infections despite prophylaxis may need surgical reimplantation. So again, the guidelines say that do not overuse antibiotics in children with recurrent UTI with vesico-uretic reflux,
Right.
right? And now I'm winding up and giving one last slide on this newer phenomena where young girls who are going to school or traveling and they are not urinating because of the non-availability of the washrooms or dirty washrooms, and because of that they do not drink water. They are having constipation because of the various causes, and this is leading to recurrent UTI or UTI-like symptoms. It may not be UTI. So once you get in these girls, if you get the urine test done, this is mostly normal. The ultrasound would show a wall bladder thickness, urinary wall thickness, which is irregular, and this is called by radiologists as cystitis. Cystitis actually is a clinical diagnosis and not radiological diagnosis, and these girls go on antibiotics unnecessarily. This I have labeled it as chemical cystitis, and this is not UTI. So in these girls, the only way is to give them good washrooms. They should drink good water amount of good water, good amount of water, and use the toilets more frequently so that they do not store urine in their bladder and do not cause problems. So with this, I would like to end my key messages that have a high index of suspicion for UTI. Get a urine culture, a proper urine culture. Febrile UTI carries a high risk of renal damage. Start antibiotics early. Use simple antibiotics for simple UTI. Use shorter durations of antibiotics. Prophylaxis is required in recurrent UTI and bowel bladder dysfunction and only in high grade UTI. Thank you very much for a patient hearing. And these are my helplines, which are open 24/7. Anytime you have any problem with any renal case, you are most welcome to contact. Thank you so much. Thank you, Dr. Tuteja.
So it was so much updated unit about our urinary infection in children and adolescents by Dr. Anand Vasudev that I am sure that viewers and the pediatrician across the country and the world will follow it, the guidelines to prevent the children from the urinary tract infection. So the school premises and the home, the mothers should train and the teachers should train the children to prevent from urinary tract infection, particularly from in the girls when the urinary tract is straight and the more chances of infection are there. And the children should report to the school if they found that the fresh room are not clean and they are stinking. They should inform to the teachers and the school authority that the fresh rooms are not clean and they can get infection from there, and that is the good cause to prevent the that can be good step to prevent the infection in the children and adolescent in the country, so that lot of antibiotic coverage is prevented to be used in the country. And for that the IAP is it's still contesting and recommending that less of the antibiotic to be used and to prevent more children from the urinary infection. Thank you so much, Dr. Anandji, to be with
Thank you.
us on this show,
Thank you.
and hope that you will come again to give the more knowledge to the pediatrician of the country. And I recommend all the IAP members to remain updated by the young, energetic faculties of IAP with us in this talk show, to subscribe the channel, to remain updated with so many things which are upcoming about the profession, about the institution, about the motivational story, about the adolescent, and so many things. And what is happening across the medical field, you will come to know from this channel only. Thank you so much.
Thank you very much and Jai Hind.
Thank
Jai
you.
Hind, sir.
Thank you.